So welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database, the monthly webinar. Today is Wednesday, February the 14th. Happy Valentine's Day to everyone. I hope you all have had a great Valentine's Day thus far. Feeling the love from everyone. Just for the agenda, I'm just going to provide some quick STS updates, and then we'll turn things over to Ruth. And then, as usual, we'll finish things up with our Q&A. Please be sure to open up that Q&A panel or the Q&A and submit your questions via that Q&A button. We do have the raise hand function enabled, so if you'd like to just ask your question, please just be sure to raise your hand. We'll unmute you. Just make sure that your microphone is enabled on your end, and then you can feel free to ask your question or just bring up anything you'd like to discuss. On the call with me today, let's see, from STS, we have myself and Carol Crone. We have Sydney Clinton, and I think Emily was on here. I don't know if she's still on. And then we have from our core group and our consultant side, we have Ruth Riley, and from core group, we have Katie joining us today. So thank you, everyone, for joining the call today. All right, yeah, Emily's still on. Sorry, Emily, your name was hidden from my chat box, so sorry about that. All right, so let's hop into our slides for today. Quick STS updates. The January training manual is posted and that is available. I have the February training manual in my hands, and I am in the process of PDFing that document and getting the bookmarks added, and that will be posted, should be posted by Friday, hopefully to be posted tomorrow. I'll send that over to Gabby later on today for posting. The supplemental neoadjuvant training manual will be posted at the end of February, and I'll be going over that, just showing you all that on our upcoming webinar on the 26th. I have a couple of questions I need to get cleared, but answered from Dr. Cedar. So I want to get those questions answered and get those clarifications added to that training manual before I get it posted. GTSD public reporting. So the public reporting website was updated on January the 18th, I believe, and it does include results from the fall 23 analysis. The official communication regarding the GTSD public reporting data refresh, again, was sent out to participants on January the 18th. As you are aware, the spring 24 harvest is currently underway, and the harvest close is quickly approaching. The spring 24 harvest will include surgery dates of January 1, 2021 through December 31st of 2023. Again, the harvest close is scheduled for March 8th. The last file deadline to get that last file in is 11:59 p.m. Eastern time. Please do not wait until the last minute to get that file in. Please, I do highly encourage you to get that data in at least a day or two prior to that deadline in case anything happens, heaven forbid, Murphy's Law, something inevitably goes wrong. So please be sure to get that data submitted prior to the last, to Friday, March the 8th. The last day to opt out of the harvest is March the 10th. And as I mentioned previously, we are going to have a webinar on February the 26th. That's typically when our user group call was going to be held. But on February 26th, we're going to have a webinar to review data cleanup prior to harvest close, just to help you guys ensure that your data is as complete and accurate as possible. Make sure you go through the proper steps to make sure, again, all your data is complete prior to harvest close and getting everything submitted in a timely fashion. So we'll review the data cleanup process on the 26th, and also I'll briefly just go over that neoadjuvant training manual just to familiarize you guys with the training manual that'll be posted. Speaking of the harvest, this slide just includes a snapshot of the the 2024 harvest schedule. You can take a snapshot, download the slide later, post it in your cube, in your office, wherever. But again, the harvest schedule for 2024. The spring 24 harvest again closes March 8th. Fall 2024 harvest closes September 6th with the opt-outs on September the 10th. All right, before I turn things over to Ruth, I just wanted to do a brief recap the STS temporary fields and the red cap, the neoadjuvant therapy module. I know we sometimes have a lot of turnover from our data manager community, and we do have some new data managers that may not be familiar with the temp fields and the red cap form. So I just wanted to give a quick overview and a recap of the temp fields and the red cap module. So as many of you are aware that due to an increased use of the neoadjuvant therapy, including the preoperative immunotherapy and targeted therapy for those patients with clinical stage 1B and higher non-small cell lung cancer, we began capturing the type and frequency of neoadjuvant therapy that is currently being utilized. So beginning October the 1st, our task force and surgeon leadership enacted 2 of our STS temporary fields. So effective August 1st, we asked for our participants to begin collecting data using 2 temporary fields. We utilized a temporary yes/no field, which was sequence 4580, and then we activated temporary text field 4620. So the questions that we are asking, that we have asked sites to begin collecting data on, again, this is for OR dates October 1, 2023 forward. The temp yes/no field, did the patient receive preoperative immunotherapy or targeted agent directed at the lung cancer of interest? Again, we're just asking you to complete that question. Just answer yes, no. And if yes, we just ask that you specify what agent was being used. So again, these 2 temporary fields, we do ask that all participants complete these temporary fields. After we began collecting data for these temporary fields, some of our surgeon leadership began working on a module to collect a bit more granular data for this preoperative immunotherapy. So we did enact a voluntary module, and that voluntary module is housed in REDCap. So we do have the neoadjuvant therapy module, and again, this module is completely voluntary. It is not mandatory. We hope that many of you, as many participants, will complete this data as possible. We would love to get more data into this module. So the neoadjuvant therapy module is answered. So if you answer yes to the STS temporary field for sequence 4580, if you answer yes to did the patient receive preoperative immunotherapy or a targeted agent directed at the lung cancer of interest, if yes, then we ask you to complete the module to capture this more granular data. Here on the right, you'll see we do have a data collection form now for this module. And this data collection form will be posted out on the STS website along with the training manual. I don't know if some of you would like to download that, use it within your institution, pass it along to your surgeon so you can see all of the questions that are being asked. But again, we would like for you to please see if you can get your surgeons to see if they're interested in collecting more of this data, but we do have this data collection form that will be posted along with the training manual. So again, this module is completely voluntary, and we ask that this data is collected on surgery dates of November 1, 2023 forward. Again, I'll go through the training manual, the supplemental training manual that will be posted in the February 26th webinar. As of right now, the training, the clarifications and all these fields currently live in our current training manual. I'm going to be pulling that out. And again, we'll just have a separate supplemental training manual just specifically for this neoadjuvant therapy module. Hopefully I didn't confuse anybody with that. But again, I just wanted to recap and just remind everyone of the temporary fields and the neoadjuvant therapy module. So we were just hoping we can get some more data collected for this module. If you have any questions, please, feel free to put them into the Q&A. We'll cover those. And if you have any other questions, please feel free to reach out to me directly. All right. One other thing we have, just a reminder, we have AQO coming up this year. It's quickly approaching. It's already February. We're going to start planning our AQO here within, I think, this next month. Our 2024 AQO will be held in Nashville, Tennessee. The dates will be September 11th through the 13th of 2024. So we will be back in person. So we hope many of you will be joining us this year in Nashville. Never been to Nashville before, so definitely looking forward to getting out to Tennessee and seeing Nashville. We'll also have a virtual component as well. So for those of you that are not able to join us live and in person, we will have that virtual component as well. We will begin planning AQO again, like I had stated here, just in the coming weeks. If you would like to be on the AQO planning committee, please feel free to send me an email. We can get you added to that. We would love to have new members on that committee and help us plan and get new ideas. So again, please feel free to reach out to me directly if you would like to be on that planning committee. And I think with that, that is all that I have. So I'm going to turn things over to Ruth so she can touch on her topics for today. Ruth?
Thanks, Leanne. So I decided to try something a little bit different this time. We'll see if this is a hit or a miss. So I get a lot of questions in the FAQ inbox. A lot of them can be answered by the training manual. It's hard to find all of the different pieces that are there. And so what I wanted to do is to sort of highlight some of the questions that I've received, because I think it's really helpful to contextualize them in the information that I'm getting from you as you're actually abstracting cases. And then providing you with the answers that I've already sent to an individual data manager, but just sort of sharing those learnings more broadly. We used to, if you've been doing the registry for a long time, we used to publish actual questions and answers in the training manual, and we've transitioned with 5211, just sort of putting in like little blurbs in the training manual, because if you look back at the previous version of the training manual, it was like pages and pages and pages of questions and answers, which was really hard to sort of keep track of. So we'll give this a whirl and see if you like it. And if not, let me know and we can switch back to going through case scenarios or other different things. So this question was about sequence 590. The question was, if a patient has a bicuspid aortic valve, do we capture this as yes in sequence 590? Or is there another place in the history where we would capture that? The answer to this question is that a bicuspid aortic valve in isolation is not captured. If the patient has documented sequela, for example, insufficiency or stenosis, then you would capture that under aortic valve disease in this instance, because it was a bicuspid aortic valve. And the picture on the right-hand side, at least in my screen, shows a bicuspid aortic valve with stenosis. Okay, sequence 1470 procedure. How do I code a case where on October 5th, the patient went to the OR for a wedge resection? Intraoperative pathology indicated that it was a granuloma. However, the final path report showed that it was cancer. It was adenocarcinoma. The patient got readmitted for a lobectomy. The data manager wanted to know whether this should be entered as two separate cases, since it was two separate trips to the OR. Essentially, it's two separate entries if you enter every single case that you perform. However, the first case ended up being a diagnostic wedge resection, which is not required for entry. You would really only be required to enter that second case, which is the curative intent lobectomy for this patient. Another procedure question, so sequence 1470, which is procedure. What do you do in the situation when a hiatal hernia case was attempted but aborted in the patient's best interest? Do we even capture the case? The answer to this question is that, with the exception of cases where the patient dies on the OR table, you code procedures as they actually occurred, not as they were planned. If the procedure that actually occurs, oh, I lost my slides. There it is. If the procedure that actually occurs is not required for entry, then you don't have to enter it. You're not required to enter exploratory laparotomies with the prayers of preparation or any of the other non-analyzed procedures. So you would not have to enter this case.
Sorry about that, Ruth. I'm a disaster over here today.
It's all right. Tech is like going to be the end of this all. Okay, sequence 1560. And I apologize. I had put what the sequences were, but then I reformatted the slides to make them prettier, and it seems that it removed the sequence titles. So let me just pull it up as I go. I'm so sorry about that. Sequence 1560 is hiatal hernia, diaphragmatic hernia, or GERD. So the question was, is laparoscopy surgical? The fundoplasty code 43280, which has an AP in front of it saying that it is actually analyzed and to be included in the hernia section. It was done in isolation. There was no hernia. It's confusing what we are to include, if we are to include GERD-only cases in additional to hernias in this section. So my response to this data manager, and part of why I included this is because, oh, no, just kidding. So only hiatal hernia repairs are part of the optional module. You do not need to enter this case. None of the cases in the optional modules are analyzed. They are actually benchmarked. I know that the hiatal hernia, diaphragmatic hernia, GERD section in the training manual is a little bit confusing. When we finish going through my slides, I think, Leanne, if we can pull that up in the training manual, I can just go through that clarification a little bit. It's tricky because I can't change the definition or the long name of the sequence. So the information removing the GERD procedures is in the intent clarification, which is not ideal. And I think that's part of what makes this tough.
Okay, yeah, sure. Happy to do it.
Okay, next one, sequence 1800 tumor size. So for this, this patient had a right lower lobe of their lung and a right upper lobe of their lung being resected at the same time. What should be the tumor size? The larger lesion is 1.5 by 1.3 centimeters, with the solid part being 0.5 centimeters, and the right lower lobe is 0.6 centimeters. Can we put 0.6 since it is the largest one? The training manual indicates that you should indicate the tumor size of the dominant most concerning lesion in centimeters, which is going to depend not only on the size, but also on the histology and grade of the tumor if you have that information. So for example, if they had done a biopsy of both of these lesions preoperatively, you would know, this one's a large cell neuroendocrine. I'm going to enter this one as my tumor size, even if it may be the smaller lesion, but because it's the more aggressive lesion. Sequence 3830, 3850, atrial and ventricular arrhythmias. The question was, what is the difference between 3830 and 3850 for new SVT that is treated with medication? The definitions of those sequences are there. The answer is that SVT is an atrial arrhythmia and is captured in sequence 3830. Sequence 3850 only captures ventricular arrhythmias, which include VFib and VTAC. And I guess that's all there. Sorry, I was thinking about something else. Sorry, Leanne.
Yeah, no, you're fine.
Sequence 4140, unexpected escalation of care. So the question here, and I've gotten a few of these lately, is they're wondering if unexpected escalation of care applies to a patient that had a lobectomy, they went to the floor, and then they have to return to the OR for another procedure. In this case, it was a chylothorax and a thoracic duct ligation. They returned to the floor postoperatively. The March 2023 update stated that it would not be captured. The data manager was thinking that it's covered under return to the OR. The data manager was thinking correctly. A return to the OR is not captured as an unanticipated escalation of care when the patient returns to the same level of care postoperatively. That's also true, like if the patient were to go from their room to the cath lab and then back to their room, it's not an unanticipated escalation of care. It's just a departure from the same level of care and return for procedural reasons. Sequence 4210, hospital discharge date. I received several of these as well this last go round. So this patient had a lung resection for cancer. They were admitted on January 25th, and then they got discharged per the notes on January 26th. They ended up going to the emergency room, being transferred back to the original hospital, and readmitted on the same day that they were discharged. The data that comes out of the hospital system indicates that the patient was never discharged, but that they remained in the hospital until February 3rd. And so they wanted to know how they should count this. So the way that I understand this is that sometimes, I think because of insurance reasons is what I've been told, and we've discussed this at the core group. Same day readmits are not appearing as discharges in the ADT. So in this instance, you'll need to use the discharge date in the dictated discharge note. So this patient was discharged on January 26th, even though the ADT may not reflect that discharge date. You can see that the patient was discharged because of the note that's in the record, and you would capture the readmission. There were a couple of questions wanting to know if a case should be included or not. I thought these might be helpful. A patient had a right-sided procedure for primary lung cancer, and then had a second procedure on the left side a couple of months later. Does the second procedure also need to be included? So this one I included just so you can see that sometimes it's helpful if you send me a little bit more data. It's really dependent on what the procedures were and if it was for the same lung cancer, because we know that we only abstract new lung cancers and not recurrent disease. With the information that was provided, it's hard for me to tell, is this new or is this recurrent? And so I just send a request for additional information, and people are usually really good about getting that to me. But just so you know, it's helpful to include that information upfront, and then I can hopefully get a response back to you a little bit quicker. Another case inclusion case, a question, sorry. This patient had lung cancer in 2020. The pathology showed adenocarcinoma at that time. Now they have a suspected reoccurrence. The wedge resection was completed, and they did decide that it was metastatic from the primary 4 years ago. The question was, does this case need to be entered or not, since it's metastatic? And again, this scenario describes recurrent disease, and we only abstract new lung cancer cases, so this case does not have to be entered. Again, some sites put in all of their cases, and that's totally fine. You're not going to complete the lung cancer section for this, though, based on the guidance that's in the training manual. Okay, a question about multiple complications for star ratings. In determining star ratings for post-op complications, there's a statement that says multiple complications, one or more of the above. Does this mean that one or more of the post-op complications are counted in the star report, or that more than one post-op complication was listed in the DCF form? When you see in your star report that your patient had multiple complications, it just means that your patient had one or more of the post-op events that are endpoints for the harvest analysis. So if you have a patient that had every single complication in the book, it's counted the same as a patient that had one of the complications that's an endpoint for harvest analysis. There's not like a double counting of post-op events that occurs.
Kind of a all or none scenario.
Yes, all or none.
All right, perfect. Thank you, Ruth. And I do know we have, do you want me to, we have a couple of questions. Before we hop into the questions, let me clarify real quick. Our, on the previous slide, I had indicated that the webinar was on the 26th. That was a typo. I'm so sorry. The webinar is scheduled for the 28th at 2:30. So it's, again, it's February 28th. I'll go back and correct the original slide, but thank you for Carmen for pointing that out. I saw you had made a comment about that. But again, it's February 28th as posted currently on the STS website. And Ruth, you wanted me to pull up the training manual. Let me do that. Sorry, I have so many screens open. Okay. Manager. Sorry. General thoracic. And back to one training manual. Alrighty. And
sequence 1560.
1560.
Yep.
Thank you. There we go.
Okay, so I think part of why this is so confusing is if you look in the title, like the long name of the sequence, It's hiatal hernia / diaphragmatic hernia or GERD. And then if you look at the definition, it says indicate if the surgical procedure was performed for a hiatal hernia, diaphragmatic hernia / GERD. But then if you go down to the intent clarification, we clarify that the field is only intended to capture procedures performed for hiatal hernias, and lined through the rest of this back in 2021, right after we first put this version into production. Unfortunately, I can't change the long names or the definitions. So the best I can do is to clarify it in the intent clarification. And I know that that makes this one super confusing, and I get lots of questions about it. I don't know if there's an opportunity to clean this up when we go to the next version, but it's definitely on the list to look at that time.
Perfect, thank you. Alrighty, okie dokie. And then our next question, Shabby, you sent an email to the help desk. You haven't heard anything back. Oh, that's that's unusual. Or gotten a confirmation that they received your email. So you should have gotten a confirmation. Your question was about an error warning message you received when you uploaded your records for 7/1/23 to 12/31/23. It was saying certain records were duplicates, or that the records did not have a change, but you had not submitted these before. And I think this has to do with perhaps the demographics. But if you could just send me the email that you sent to them and I'll forward it on, but you should have gotten a confirmation. But again, it's just a standard message that is displayed within the IQVIA platform. If a record is resubmitted and there were no changes, it just gives you a warning message, or a warning message saying that there were no changes. But no, each time you submit your data, we get all of your demographic records and not just the demographic records for that particular time frame that you're submitting. So I think that may be what's happening. I'm not sure, but if you could again just reach out to me directly, and we can get an answer from you, or an answer for you. So sorry about that. Okay, next question from Joanne. Ruth, she struggles with follow-up on complications and readmissions. Her doc typically does 2-week follow-up appointments, then 6-month. She's contacted PCPs, pulmonary, and patients in access care everywhere, and cannot get the complete info when it doesn't exist in the medical record. Since no documentation, cannot infer that there was no complications, readmissions. Do you have any other recommendations?
I don't know if your surgeon's office is willing to help out. Sometimes patients will recognize that phone number and are more likely to answer if you're already directly calling patients and they're just not responding to your calls. A lot of people are screening calls anymore. Other than that, it sounds like you're doing a pretty exhaustive search, Joanne. If anybody has any other suggestions besides what she's already doing, feel free to put it in the chat, but I don't, unless your physician is willing to change the schedule for their follow-up appointments, which I'm guessing is probably not on the table.
Yeah, I don't know. Katie, do you have any ideas or?
Well, I'm not sure if when she's contacting these other offices, are they saying that, I mean, I guess if they're telling you that the patient hasn't been readmitted or there's no complications, or you do have like a verbal from somebody, perhaps you could find a way to get somebody to note something in the record. I asked my surgeons to add a little blurb in their post-op note, just saying, have there been any interval, readmissions? And it's just a simple yes, no. And I still sometimes have to ask them to do it, because a lot of my surgeons, especially if there's no complications, they'll see the patients at 2 or 3 weeks post-op and they don't see them again. So sometimes I do have to do a little extra legwork. But I think if you have a verbal from somebody, no matter what office it is, if you could get whoever that was to put it in the record, and then you have that there. I don't know if that's if that's the roadblock, or if it's you're not getting any information from anybody. And in that case, I think at the end of the day, you have to just put it back on your surgeon and or office, and let them know that you can't, your data is incomplete without that information, and you're not really able to submit complete information to STS without it.
Gotcha. Thank you. I see Dion had put some information. She always asks the NPMA for that physician to reach out to do a televisit or a follow-up to answer those two questions if they cannot get through. It's also in their 5-week post-op note, virtual and in person. Thank you. Oh, my questions are jumping around. All right. Thank you, Katie. Thank you, Ruth. Joanne, I hope that was helpful. And Brooke, again, yes. So again, just to reiterate, the next webinar is February 28th, not the 26th, like I had mentioned earlier. Sorry about that. Our next question from Jeremiah, sequence 790, history of substance abuse. If a patient is currently on Subutex, oh, those are big words.
It's all right.
Don't make me read those words. Help me.
If they're on Suboxone, is that captured as a history of substance abuse, substance dependency? I would say yes, but I can confirm this with the core group when we meet on Friday. We have already stated in the training manual that alcohol abuse is captured for patients in the sequence who have a history of alcohol abuse that are currently taking antabuse under clinician direction as part of treatment for alcohol abuse. So I would think that Suboxone falls into the same exact pattern, but I can confirm that with that group on Friday and then update the training manual for March.
All right. Thank you for saving me there. Next question from Cassie, or she says, if I find out that a patient diagnosed with recurrent laryngeal nerve paresis right at the 30-day mark, but they are being scheduled for an additional appointment at a later date to determine how to manage it, how would I answer the grade question? Since it won't be determined until after the 30-day mark, how will it be managed?
Cassie, do you want to just send me that in the FAQ inbox if you haven't already?
We have a call Friday, I believe.
We do.
Yeah. That's a great question. All right. Are COVID patients still excluded from the star rating? I believe that is addressed. Is that addressed in the analysis overview? What do we have?
So.
Yeah. So, yeah. So, Shelby, here in the analysis overview, we have the information here about COVID data. So, for analysis exclusions, cease for any record with a surgery date of January 2022 forward. So if their OR date is January 1, 2022 forward, if they're COVID positive, they are included in the analysis moving forward. But prior to that, they are not. Let's see. Temp text field, are you wanting only the immunotherapy drug or the whole set of drugs? Ruth, do we have clarification on that?
I'm scrolling. We have several questions on the temporary text.
Yeah, we can.
I think they're looking, so my interpretation of the definition, which I can clarify again with Dr. Cedar, is that we are looking specifically for the immunotherapy or targeted agent in that temporary text field, not for you to list out all of the drugs that the patient was receiving.
Yeah, I forgot.
But I can clarify that with Dr. Cedar again.
Yeah. Thank you.
Leanne, we might want to set up a separate meeting with Dr. Cedar just to go over all these red cap text questions so that we have time on the core group call to make it through the rest of the questions.
Got it. Thank you.
Thank you all for sending in so many great questions on the red cap and the temporary text sales.
Yeah, definitely want to get those answered before the next webinar. Brand new to thoracic database. My question is, How do I code a bronch with electromagnetic navigation? How is this different from EBUS?
EBUS is endobronchial ultrasound. So they essentially, they use an ultrasound probe, sort of like, oh, I'm trying to think of what, like an EUS, so an endoscopic ultrasound, to look for, they look generally at the lymph nodes when they do an EBUS. And no, navigational bronchoscopy is generally a pairing of CT images with a device that helps the biopsy probe make it out into the peripheral tissues of the lung to find the tumor that they're trying to biopsy. So this is an overgeneralization because the technologies, of course, are constantly changing. But generally speaking, the navigational bronchoscopies were traditionally biopsies of the nodules, whereas EBUS was more traditionally a biopsy of the lymph nodes. And navigational bronchoscopy does have a CPT code in the under sequence 1470.
Alrighty. Recap data question. Does the question about pathologic response upon resection pertain to just the primary tumor? Saw a patient recently who had a complete response to the neoadjuvant therapy on final path, but she had positive lymph nodes resected at the time of surgery. How would this be coded? Did we?
I think we're gonna have to ask Dr. Cedar that one too.
Okay.
Mary, if you wouldn't mind just popping it, I'm gonna type my STS email address in the chat as a response to your question. And if you just send it directly to me, that'd be great.
Okay. Ooh, everything's jumping around. Okay, hold on, dude. All right. Let's see. Has there ever been consideration for Zoom calls webinars related to specific topics or groups of topics? Example, lung cancer staging, procedures path, common esophageal or lung cancer procedures, maybe like question and answer part of the current webinars, but on more narrow topics. So thank you for saying that. But yes, and actually Carol and I were just talking about this earlier this week. We are going to be developing educational plans for the webinars moving forward. So yes, we are going to, again, just work on some plans and have webinars dedicated to more specific topics. Because we want to ensure that you guys are getting the education that you need. And then if you have additional ideas, please share those with us so we can, again, make sure that you guys are getting the education on the topics that you would like and that you need. I know we get a lot of questions about staging, nodes, anything, just please let us know what you guys would like to have webinars on. And again, Carol and I and team will work on those educational plans and have these webinars laid out moving forward. Next question, 3900 Ilias. Instructions say greater than 3 days requiring treatment. Example includes NG tube insertion for decompression. Is intent only NG tube for treatment, or can it be bowel program, enema, diet changes? 300. I can pull that up if needed. Does Ruth, any idea on 3900?
We can take that one to the core group.
Okay. It's a great question. Tracy, it would be helpful to have a document with submitted questions and the answers where sites could search for questions previously sent in to see their current question has already been answered. That's the way that the previous training manual was set up. And we used to include every single question and every single answer. And it's the way I think all the training manuals were, but we changed that format because that, believe it or not, caused a lot more confusion. And then we would, because each individual scenarios, it really caused a lot of confusion. So we switched it over to Ruth, will answer each the specific questions. But if she continues to get like questions that are asked commonly, that's when we update the training manual with intent clarifications. So we'll take those questions that we get most often and over, and we'll update the training manual to indicate to clarify those questions that we are getting over and over and over. But if you're not sure, please just submit your question. If you look in the training manual and you don't see the answer, but please just always check the training manual first prior to submitting your question. Then if you're not seeing the answer, if you're not sure, just please submit that FAQ and we'll get that answer for you. All right. Next question. Several questions regarding how to submit to the STS. You've been having trouble with this at my hospital. So there's someone, yes. Anna, if you can email me directly, I'm going to put my email address in here, sts.org. You can email me directly, and if needed, we can just set up a quick little time to chat, and I can help you in any way that you need. Sue, will we receive an email previous to harvest closing in regards to not meeting the 2% threshold or missing 30-day status for lobectomy, primary lung, and esophageal cancer? Yes. So yes, we will be sending out those emails as well, Sue. My surgeon has heard that the public reporting for lobectomy star rating may be going away in favor of the lung resection star rating. Is this something that might be coming in the future? So yes, Robin. Dr. Cedar presented at this year's STS annual meeting on the STS risk model. So in the near future, which we'll obviously be providing more education on and more communications will be coming out from the STS about this, public reporting will be moving towards the lobectomy will be replaced with the resection composite. So again, more information will be coming soon about this information. So just stay tuned, and we will be sharing more information as soon as we get all of the information in line, and we'll be presenting actually, to the data manager community, the plans on all of this as well. So stay tuned for more information coming very, very soon. How are not major complications like atrial arrhythmia, urinary retention incorporated in the star rating calculations?
Essentially, they're not. Do you have the analysis overview pulled up?
I sure do.
So if you look through the analysis overview, it'll tell you which data elements will impact the star rating, like what goes into that calculation. So it's only these major complication endpoints that are rolled into your major morbidity calculation.
Yep. And also the risk model covariates are here as well.
And if, just an aside, I've had several emails too about like people looking for patients that they felt like should have been in their last harvest, but weren't in their last harvest. If you scroll up a little bit, Leanne, in order to be included in the harvest, your patients have to meet all of these criteria. So they have to have one of the following categories of disease, and, which is very important, and one of these procedures. And then there's a whole section on what's included and excluded. So for example, elective procedures are included, meaning anything that's palliative, urgent, emergent is excluded. So if you have a patient that falls into that category, you're not going to find them in your analysis. And then there's, if you're missing empty DC stat, your patient would not be included in the analysis. So there's all these things you sort of have to roll through to make sure that your patient really is missing from your analysis.
Excellent, thank you. Next question from Christina. How does ECOG score play into the star rating? I have several missing ECOGs and wondering if it could affect whether we are a 1, 2, or 3-star facility.
So your patients that are missing an ECOG score will be included in your analysis. However, they're risk adjusted to the lowest risk possible, meaning we're assuming that that patient is happy, healthy, and jogged into the hospital to have their procedure done, which may not be the case. So an accurate functional status will allow your patient to accurately be risk adjusted, which is really important when you think about how the analysis occurs. So it could affect whether you're a 1, 2, or 3-star facility, not because your cases are being excluded, but because they're being inappropriately risk adjusted.
Right. Yep. You want to make sure your surgeons are or your your ECOG is documented. Let's see here. Oh my gosh. Let's see. Carol, this is a question for you. I don't know if you're able to answer this one. I don't know if you're but she was on they were on the cardiac webinar last week, and it was noted that frailty inputs are going to be added effective April 1, 24. Is there any date or information on when frailty is going to be added to GTSD?
No, but it was, no, thanks for the question, Leanne. Hi, everybody, it's Carol. We did hear from Dr. Weiler von Balmus that the frailty measures are something that will be coming to GTSD. We're starting in ACSD. There's no time frame right now for expanding this into other databases other than just saying that it will be coming. I would not expect this to hit GTSD probably until earliest 2025, mid 2025. I think we need to get it started with an ACSD and work out any kinks, and then go on from there. So no hard dates yet, but it's something that will be coming likely within, the next 2 years.
Awesome. Thanks, Carol. Jackie, where do you submit data for review before the harvest? So you submit your data to IQVIA within the IQVIA platform. If you're not familiar with that, just please shoot me an email and I can help you introduce you to the IQVIA platform and show you. You should have your credentials to log in and submit data if you are given permission. If you are someone who's assigned as a primary data and file contact, you have to have permissions to upload data within the IQVIA platform. It's all based upon which role you're assigned by your hospital. So when you're listed as a contact for your site. So if you could just shoot me an email and I can help you figure out what's going on if you have the permissions that you need to upload your data within the platform. Next question, I have facilities that only submit lobectomies. Is this something they should know to be collecting other procedures?
No, well, so all pulmonary resections for lung cancer should be submitted. And then all esophageal cancer resections should be submitted. They aren't required to submit the optional modules, but if there's required procedures that they aren't abstracting, then yes. And I think the beginning pages of the training manual outline the required procedures.
Yes, it does. Where did it go? It's under general information, procedure inclusion. Is located here on the first page. Let's see here. Enter data directly into the IQVIA platform, and reintubation is not listed as a field under pre-op.
I think she's saying
Post-op,
post-operative comps, yeah.
Post-op complications.
Yeah. No, it's just not called reintubation on the data collection form anymore. It's sequence 3760, which is respiratory failure.
Right.
And I think historically the long name for that field was reintubation. If you look at the analysis overview, it'll tell you what sequence number we're referring to, because the sequence names on rare occasion do change between versions. We try really hard not to do that, but it happens sometimes.
Is there a reason you can't see PFTs in IQVIA to know percentage of the patients marked yes or no? So I think are you talking about within the participant dashboard, Nancy? Or Nancy, I'm sorry. In Wilson. Okay. Let me take a look at that at the dashboard, and I'm going to make a note of that and see if we have that listed as an enhancement if it's not currently reporting that information out. So PFT percentages. I'm making a note in participant dashboard. And if you want, you can email that to me directly too, so I don't. So I make sure I get a response directly back to you. If you could do that, that would be great. And you can email me at ljones@sts.org. Just submit that. Just email me that question right there, and I can, and I'll get that response for you. When is the next version of the DCF expected? So right now, we don't have an upgrade planned in the anytime soon. I know STS Surgeon Leadership doesn't have any upgrades planned for any of the databases within the next year or two. So at this time, we do not have an update on when we are expecting the next upgrade. But as soon as we find that information, obviously we'll share that with you. But as of right now, we do not have an upgrade planned within the next year or two. Where do you submit data to ensure if you fall below the required data cases before March harvest? So you would submit, Jackie, you would submit to the IQVIA platform is where you submit all your data. So if you just want to shoot me an email, Jackie, and we can set aside some time and I can meet with you and I can go through your questions and walk through the platform with you and introduce you to how you submit the data and walk through the platform. And you can reach me at ljones@sts.org.
Hey, Leanne Jones.
Hi, Carol Crone.
It's Carol Crone. There was a comment from Shabby Bakla-Chandran regarding an email. I spoke with our support team, our help desk, and I understand that email was sent to us encrypted and that they had reached back out and asked for it to be resent unencrypted. So if Shabby, if you could please resend that email unencrypted. STS doesn't usually open encrypted emails from outside organizations. So if you could unencrypt it and send it back to us, just make sure there's no PHI in it. I'd be happy to help you with that. And I hope that helps. Thank you.
Thanks, Carol. Arnett, can you show a sample of how the physician report looks like in your next webinar data manager meeting so that we can show our surgeons? I do not care. I don't know, Carol, if you have an example of this.
No, I sure don't. I don't have an example.
If you could, AJ, I don't know who AJ is, but if you could reach out to our national database team, STSDB@sts.org. Jane and her team, they handle the surgeon level reports. So they may be able to provide you some assistance there, but I do not have a copy of the physician report. So, and again, it's STSDB@sts.org. You could email Jane and her team and they may be able to assist you with that. Okay. I don't have any other questions. So it looks like we are just about at time. I don't know, Ruth or Katie, do you guys have anything else for everyone today? I know we have our core group call this week. So we'll have some responses for FAQs that have been submitted. And we've got quite a few that have been coming in lately. So we will get those responses to you after core group. And the February training manual, I hope to have that posted. See if Gabby and her team can get that posted for me tomorrow. And again, please feel free to reach out to me directly. I gave a couple of you my email address. So again, just reach out to me. I can help you with understanding that IQVIA platform, how you submit your data, get your questions answered. So please contact me directly. With that, I think we'll go ahead and close out. I don't see any other questions. So thank you, Katie and Ruth, Emily, Addie, Carol, for being on today. I appreciate you guys.
Yep, so great job, Leanne Jones, as always. Thanks, everybody.
Thanks, everyone. We'll see you on February the 28th for our pre-harvest close webinar. So again, if there's anyone out there that wants to be on our AQO planning committee, please shoot me an email address or shoot me an email. We'd love to have you join us. and just reach out if you have any questions. Thanks, everyone. Hope you guys have a great Valentine's Day.